Okay.
John Marshall, Ben Weinberg. It's Sunday afternoon. The plenary session is just emptying out. And for whatever reason, the number one abstract at this meeting was a colon cancer abstract. No new drugs, no new nothing. So why was it the number one abstract?
Yeah, I mean, we don't always get a GI plenary abstract, so it's always fun when it happens. So there's been several studies over the years, somewhat similar in design. Frontline colon, do you give an EGFR drug like Vectibix, or do you give Avastin with your chemo? And, you know, some of the studies done in Europe, some done in the US, this one done in Japan. And we've gotten better at selecting for the group that benefits, right? So everybody on this study had to have a left-sided primary tumor. So if your tumor started near your liver, you weren't invited. They actually did include those patients, but the primary outcome they were interested in were the folks with left-sided primary tumors without a RAS mutation. Did they benefit from chemo with EGFR blockade or
and
chemo
no
and
HER2
Avastin?
testing, right?
No HER2, no BRAF.
No BRAF
that I
testing.
could. So you know, you could even
Make it better.
further make it better, and maybe you get these yin-yang curves where actually the bevacizumab group does a little bit better earlier, and then they kind of cross in the middle. But then the tail is such that the EGFR group does better. And I've always said from 80405 that the survival curves don't separate until 11 months. That's usually when people are having their first progression event on their frontline therapy. But the overall survival curves stay separated for years. So by giving the EGFR drugs first, it's almost like you're selecting for a more sensitive clone to subsequent lines of chemo. Maybe getting rid of the EGFR sensitive clone earlier is better. And then
Well, we've been good partners, right? But I've not done that. So
Yeah.
I've been on the other side of that and said, I hate the rash.
Yep.
I don't want to deal with
Yep.
it. Am I wrong?
Yeah.
Okay, that's what I think too. I think I've been wrong all along.
Because you could say you're giving up 3.6 months of median overall survival
Which
as
you
a
can't
result.
leave on the table.
Which you cannot leave on the table, but you don't see it for years, right? So it's hard and the hazard ratio is only like 0.8. It's not a huge
But it's a
difference,
real number.
but yeah, over time, if you put enough patients on, you will see a difference. But the other people will say, well, only about half got EGFR, in the second line. So maybe if they had all gotten EGFR,
Might come out
would it come out? But for some reason, they're not. And whether that's a selection bias or a doc bias, we don't know. But
Do we have a formal time now to separate out, like they do in breast, of ERPR, HER2, triple neg? Do we have RAS mutated, RAS wild type, and then sort of MSI, HER2, BRAF? Should we think about all of those diseases differently now?
So, yeah, and I think Dr. Kremlini, who was the discussant, did it well, where she said, the MSI high group, they get immune therapy, right? The BRAF group, they should probably get intensified chemo with VEGF. But the left-sided RAS wild type, BRAF, wild type, MSS, they should be getting EGFR with doublet or triplet chemo, and then the right-sided, they clearly still do not benefit from EGFR, and Dr. Yoshino also showed that data, which was nice, even though it was only about 20% of the patients. The focus, again, be on the left side.
Very cool. We got to cut it right there.
Yeah.
New standard of care in colorectal cancer, new shortened guidelines, whole thing, based on the plenary today. Not a new drug, but a new standard of care. Thanks, Ben Weinberg. Bye.
Great.
That was it, yeah.